Hello, I'm Karim Fizazi, medical oncologist from Institut Gustave Roussy here in Villejuif, France. Thank you for joining me today. When you think about it, prostate cancer was actually the first cancer where immunotherapy was ever tested. And that's actually back in the 90s in San Francisco, where CTLA-4 inhibitors were first investigators in men with advanced disease. And there was obviously rationale to do so. Phase 1 and phase 2 showed some efficacy from Ipilimumab, a CTLA-4 inhibitor used intravenously. And this led to development in a phase 3 trial, and actually 2 phase 3 trials. The first one was conducted in men who had failed hormonal therapy, but also docetaxel. And at this time, back 10 years ago, there was not much options to propose to these men, unfortunately. Ipilimumab was combined with local radiation therapy directed to bony lesions, and this was compared versus the radiation therapy alone with, of course, a placebo. When the data were first analyzed, overall survival was not significantly improved, with a p-value of 0.053, indicating that there was a trend, but not confirmation that OS was actually really better. So why is that? Progression-free survival was clearly improved in this trial, but for probably one of the first time in immunotherapy trials, what we saw was that patients receiving Ipilimumab initially tend not to benefit, and actually the Kaplan-Meillers showed that the curve of Ipilimumab was worse initially as compared to the placebo control arm. But after 6 months or so, the curves tend to cross so that the Ipilimumab arm looked better after this period of time. But overall, the difference was not significant, unfortunately, and the trial was considered as a negative trial. Having said that, even at this time, we saw some patients benefiting tremendously from CTLA-4 inhibition. And for example, as you can see here on the screen, this is one of my patients who was treated more than 10 years ago now with terrible disease, bony metastasis everywhere, progressing after the docetaxel on pain, requiring opioids to treat the pain. Ipilimumab had a major effect against the cancer, with the pain completely disappearing, PSA going down from more than 100 down to 0, and it's been continuously to 0 since then, and the burn scan basically normalized. So this is really unique. You don't really see those things appearing with other treatments, except with immunotherapy in this disease. And actually, with a longer follow-up of this first phase 3 trial of Ipilimumab, we saw that this gentleman was not just one, and actually that there was an excess in long-term survivors, some again in long-term remission for a very, very long period of time. So immunotherapy clearly works in these men. The question was really, can we identify who they are? And obviously, we had to find biomarkers, and we're still, of course, working on this. After CTLA-4 targeting had basically failed to demonstrate meaningful benefit for these men with advanced prostate cancer, and when I'm saying meaningful, it's meaningful according to the agencies, FDA and EMA, for approval. Because, again, in some men, the benefit was meaningful at an individual basis. But anyway, after CTLA-4 had failed, there was a period of time where immunotherapy was not really tested. And then out of a sudden, investigators in the West Coast, in the US, decided to test PD-1 or PD-L1 inhibition after enzalutamide had failed. And to do this, they carry on with enzalutamide and they added pembrolizumab on top of this next-generation hormonal agent. What they reported was that in some patients, it works, and it works actually like magic. As you can see here on this table, 5 patients with very advanced disease and very high PSA and a quite large burden of disease experience a very impressive reduction in their PSA. And this was actually associated with measurable reduction of the disease in some men and clinical benefit on top of this. Already at this time, it was identified that some of these men had MSI-high cancers, but not all. So MSI-high, and we will come back to that, is obviously a very important biomarker, but it's not telling us the whole story regarding the benefit from PD-1 inhibition. Then, of course, there was more experiences with pembrolizumab. For example, the large international Keynote 199 trial was conducted with hundreds of men treated. And at the end of the day, this confirmed that some men benefit, but some men only. And actually, most men that we will treat with pembrolizumab in this situation will not derive benefit, which means that we should try our best to identify biomarkers predicting for efficacy. Based on this data and other data from MSI-high cancer trials, regardless of the primary cancers, pembrolizumab was approved in the US, and which I think is a very reasonable thing to do in men with MSI-high cancers or MMR-positive cancers, while unfortunately at the moment in Europe, we don't have such an approval, and I hope that VMA will change their position regarding this. The safety data profile from pembrolizumab in men with prostate cancer is actually the one you would expect from other experiences with these agents in other cancers such as kidney cancer, lung cancers, and others. And it's basically all what stimulation of the immune system can actually produce. So it might be GI toxicity with nausea or diarrhea, it might be fatigue, it can be thyroid toxicity, and actually it's a quite long list. The good news is that those side effects are not very frequent. They need to be monitored, and of course, when they appear, you should consider stopping pembrolizumab, and in some cases, using corticosteroids or other immune-stopping toxicity strategies, if you will. But again, it's generally speaking a well-tolerated drug as far as it is monitored rightly. Most guidelines currently recognize that immunotherapy has a place in the treatment of men with advanced prostate cancer. Of course, the NCCN guidelines support pembrolizumab for MSI-high cancers, and this is associated with approval, but also in men with high tumor mutation burden. This is also reflected in other guidelines, and for example, here in Europe, the ESMO actually says that patients with MSI-high cancers can actually benefit from immune checkpoint inhibitors, and those treatments should be considered in these men, even in, unfortunately, we don't have approval for this treatment as I'm speaking right now.
My name is Sandy Srinivas. I'm a GU medical oncologist and a professor of medicine at Stanford University in Stanford, California. Many tumors today we have checkpoint inhibitors that have become mainstay. That hasn't been the case in prostate cancer to date. So other than Sipuleucel T, a dendritic cell-based vaccine, we don't have immune checkpoint inhibitors in common use in prostate cancer. It hasn't been for lack of studying. There have been multiple trials that have been done. One of the earlier trials were using single agent Ipilimumab. It's been studied in patients post-radiotherapy, as well as in patients who were chemotherapy naive. And in both trials, there wasn't an improvement in overall survival, though over a period of time with subsequent follow-up, there have been improvement in overall survival compared to placebo. Attempts to then combine immunotherapy with other drugs have been underway. The Ambassador 250 trial, for example, combined atezolizumab with enzalutamide and was a negative trial. Single agent pembrolizumab has been studied in smaller trials such as the Keynote 028, as well as in the larger trial with Keynote 199, which looked at patient populations with PD-L1 positive, PD-L1 negative, and overall the response rate was quite low. Again, attempts to combine checkpoint inhibitors with other drugs have been published to date, and Keynote 365 is a trial that combines pembrolizumab with either olaparib, chemotherapy, or enzalutamide, and the responses have been variable. A similar trial, the Checkmate 9KD, looks at nivolumab with docetaxel, and the responses have been in the 40 to 45%. The contribution of checkpoint inhibitors to chemotherapy remains to be determined. So overall, data from these trials demonstrate that a small subset of patients with prostate cancer respond to single-agent immune checkpoint inhibitors. We clearly need to identify biomarkers as to who these group of patients who respond are, so that we could spare the rest of them the adverse events associated with immune checkpoint inhibitors. The tumor microenvironment of prostate cancer is quite complex, which includes T cells, it includes the stroma, it includes the cytokines that these cells release, as well as the vasculature. And this complex interplay between these result in an environment that is quite hypoxic, that has resulted in dampening the response of immune checkpoint inhibitors in prostate cancer. I'm going to break down the tumor microenvironment and talk about the T cells, where we do have increase in the myeloid-derived suppressor cells, which release TGF-beta, which could be immunosuppressive. There are issues with the population of T cells, which are the tumor-infiltrating lymphocytes, which have been really a good predictor of immune response in other cancer types. But in prostate cancer, the type of TILs that are present are the CD4, FOXP3, CD25 cell population, which have been associated with a suppressed immune response. There are also the tumor-associated macrophages, which are present in large numbers, again, secreting high levels of TGF-beta, which have also been responsible for a suppressed immune response. The cytokines have been an interesting story as well. We do find an increase in chemokines such as CXCR4 and CXCR5, which have also been associated with a dampened immune response. Some of the tumor mutational burden, which have been predicted to be a high which have been predicted to result in a high response in other tumor types in prostate have been significantly lower, in a fraction of 5 to 10 times lower compared to cancers such as melanoma and non-small cell lung cancer. So in prostate cancer, pembrolizumab has achieved FDA approval in the United States for patients who have an MSI high or tumor mutational burden greater than 10. And this represents a very small fraction of patients with prostate cancer. There are many guidelines that are used nationally and internationally. The most common ones in the United States is NCCN, and you have ESMO and EAU used across globally. Most of these guidelines are consistent that tumor testing, especially for patients with metastatic CRPC, since we have therapeutics with PARP inhibitors, all guidelines recommend tumor testing for alteration in the homologous recombination DNA repair genes. And if they were to be positive, then therapeutics such as olaparib is recommended. Tumor testing for MSI high or deficiency in the mismatch repair genes is recommended, if not previously done, by most of the guidelines. It's strongly recommended that tissue biopsy is done when available. And if tissue biopsy is not feasible, then liquid biopsies with ctDNA testing is recommended by most of the guidelines. If MSI high is to be tested, it is preferred to do next generation sequencing rather than immunohistochemistry if possible. So in the future, we look at solid tumor biopsies versus ctDNA testing. The field is moving towards liquid biopsies because there appears to be concordance between tissue biopsies versus ctDNA tests. There are obviously pros and cons associated with each one of this. When tissue is available, solid biopsy is definitely preferred and recommended for obvious reasons that it allows us to sample a more enriched tumor population. There is intact genome. We have better access to the tumor microenvironment, and larger panels are available with larger amount of tissue. And these can detect, again, both somatic as well as genetic alterations. Obviously, the downsides are that these are invasive. And most important in prostate cancer is that given that patients with prostate cancer have dominant bone disease, access to tissue can sometimes be a challenge. Doing DNA testing on bone can also be sometimes challenging as well. Using ctDNA clearly is more convenient. It can be repeated. It can detect, again, somatic as well as germline alteration. And again, it appears with more contemporary testing that there is a high concordance with tumor biopsies. The downside of ctDNA is that it may not truly reflect viable CTCs. There's also a concern for detecting clonal hematopoiesis or CHIP. They could be false positive that can be detected with liquid biopsies. The future, however, is looking at new biomarkers. We have had PD-L1 expression now for more than a decade. It has somewhat been conflicting results in prostate cancer. Keynote 028, for instance, suggested that PD-L1 expression resulted in a higher response rate. However, the larger trial with Keynote 199 did not demonstrate PD-L1 as a useful biomarker. So I do think that the value of PD-L1 expression as a biomarker in prostate cancer remains to be determined. I am excited about some emerging data about the relationship between ultra-mutated states with POL1, POL and POL-D1. These presence of these mutations do result in a high rate of single nucleotide substitutions, and these ultra-mutated states may result in a higher response to checkpoint inhibitors. In fact, there's been a case report of a patient with POL1 mutated tumor that has resulted in a deep response to immune checkpoint inhibitors, and larger trials are underway. CDK12 is also an interesting biomarker. CDK12 controls DNA damage response, and loss of CDK12 has been associated with focal tandem duplication, increased gene fusion, neoantigen burden, and T-cell infiltration, all of which have been associated with a higher response to checkpoint inhibitors. A small case report of more than 8 patients have resulted in a PSA response in a third of patients. And again, larger trials are underway. So I'm excited about some of these potential biomarkers for use in patients with metastatic CRPC.
Hello, my name is Johann de Bono. I'm a professor of cancer medicine at the Institute of Cancer Research and the Royal Marsden Hospital in London. Immune checkpoint inhibition has shown quite spectacular benefit to patients in multiple diseases, including melanoma, bladder cancer, lung cancer, but has to date been really quite disappointing in the treatment of prostate cancer, apart from perhaps a small subgroup of disease of prostate cancers. There has been quite a lot of clinical trial efforts studying monotherapy immune checkpoint targeting antibodies in the clinic. For example, there have been 2 big Ipilimumab randomized phase 3 trials, both pre and post chemotherapy, that really have shown no significant survival benefit, although there was a very minor improvement in PFS of less than 2 months. And without an improvement in OS, I don't think this really can be deemed to be something to be pursued any further as a single agent. The Keynote 199 study pursued pembrolizumab as a single agent, and I led this trial. And in this trial, we had 3 cohorts, PD-L1 positive, PD-L1 negative, and a third cohort with bone-predominant disease. And I think the most important message from that trial is that a very small proportion of patients, particularly those with mismatch repair defects, have really impressive durable responses. But the response rate is very low, 5-10%. So again, apart from that patient subset, I don't think pembrolizumab single agent or PD-L1 targeting as a single agent is going to be really impactful in advanced prostate cancer, out with mismatch repair, maybe CDK12 biallelic loss tumors. Atezolizumab has also been studied as a single agent, and in fact has been taken forward in a large randomized phase 3 trial as well, with enzalutamide. Again, the results have been disappointing, both in the single agent studies as well as in the phase 3 with enzalutamide, which failed to meet its primary endpoint. So overall, I think the data would indicate that these immune checkpoint inhibitors have some merit in a very small defined subgroup, for example, mismatch repair defective disease, prostate cancer. But as for the whole population, I doubt that these drugs really merit further evaluation as single agents. The rationale to using combinations is to try and increase that anti-tumor activity and reverse the immune tolerance that seems to be operational in these immune cold tumors. And, multiple combination trials have been pursued, including, for example, combinations of PD-1, PD-L1 with CTLA-4 targeting, combinations with PARP inhibition, even abiraterone and enzalutamide, and other immune checkpoints, and including also most recently combinations, for example, TIGIT targeting antibodies. More recently, with some more promise, is combinations targeting multiple kinases that may increase T cell penetration into the tumor. So this is really quite a burgeoning area of research. But I think the main message today is that the results from monotherapy have been today disappointing. Prostate cancer appears to be immunologically cold with exhausted T cells, and combinations that can reverse that T cell exhaustion may be a way forward to increase the anti-tumor activity of these therapeutic strategies. So there are multiple drug combinations being studied with PARP inhibition and immune checkpoint inhibition. For example, pembrolizumab is being studied with olaparib. But there are other trials looking, for example, at durvalumab with olaparib, nivolumab with other PARP inhibitors. So I think this is an area of fairly extensive research, clinically and preclinically. The rationale here is that PARP inhibition may activate the immune response by activating the sting response. PARP causes DNA damage. You get release of double-strand DNA fragments into the cytosol of tumor cells, and that may activate an immune response. So to be honest, the results data with these combinations have really not been that impressive, in my opinion, and may depend primarily on patient selection. For example, selection of patients with DNA repair defects. And certainly the pembro plus olaparib combination response rates at less than 10% have really been quite, in my opinion, quite disappointing. Although the response rate of durvalumab with olaparib has been a bit more promising, although the number of patients treated are small. This is work coming out of the NCI in the US, led by James Gully and others. But really we have to figure out, is patient selection playing a role in the higher response rates seen in that trial? So this is an area that is gaining quite a lot of credence. And indeed, in other diseases like endometrial cancer, multi-kinase inhibitors with PD-1, PD-L1 targeting is showing huge promise. And I am convinced that perhaps the TKIs, the tyrosine kinase inhibitors, are allowing T-cell penetration into these tumors, and that perhaps this is the reason for the increased response rates being seen in multiple tumor types. For example, cabozantinib, levantinib, these are drugs that are showing promise in combination. Certainly work led by Neeraj Agarwal, presented at ASCO, seems to indicate that when you, for example, combine cabozantinib with atezolizumab, you get much higher responses than we've seen with PD-1, PD-L1 alone. In this cohort 6 of its phase 1b, small number of patients, 44, where the primary endpoint was overall response rate. In this expansion, we see a combined overall response rate of 32% with a confirmed PSA response rate of 67% and a disease control rate of 80%. While this combination is fairly toxic, quite a bit of side effects, the results really are quite impressive with some meaningful, durable responses. So it's our hope that these combinations will have an impact in the care of advanced prostate cancer. But we await the phase 3 trials, and at present, this is really conjecture. There are many different combinations being pursued. For example, the one that's been studied most, I think, is the CTLA4, PD-1, PD-L1 combinations. These are showing some anti-tumor activity, although in my opinion, it's still quite disappointing and really quite toxic. For example, nivolumab has been studied in CheckMate 650 with Ipilimumab. There were pre-chemotherapy and post-chemotherapy cohorts, not large patient cohorts, 45 patients in each group. But what we saw here is significant, really quite significant toxicities in these trials, like grade 3-4 TRAEs of almost 50% or around in both groups. And although there was some evidence of anti-tumor activity, I would say this was fairly disappointing. The overall response rate in cohort 1 was 25% pre-chemo, cohort 2 was 10% post-chemo, with a fairly short time to median progression. And in this trial, multiple deaths on study, which really makes me concerned about pursuing this combination any further in clinical trials. Neptunes, the cohort 1 of Neptunes has also studied nivolumab, ipilimumab. We had a combined response rate here. It's not that different to CheckMate 650. Again, significant amount of toxicity. In this trial, there was some attempt of selection, although I would argue this did not really particularly help us get a better response rate, sadly. So I think this trial hasn't really shown us much of a difference, although the trial did confirm anti-tumor activity in mismatch repair defective disease, although the results in the CDK12 population was quite disappointing, and the patients with the high tumor-infiltrating lymphocytes in this trial did not really seem to have much of an increased chance of benefit. Again, this combination is quite toxic. There was also a further small study of 15 patients called CRPC, which again really had very similar anti-tumor activity and again fairly high toxicity. So I'm really concerned this combination, particularly in this elderly population of men with advanced prostate cancer, is probably not one that we're going to pursue further long term to impact outcome from these diseases. Well, I would argue that at present the TKI combinations are perhaps, one of the more promising ways forward, and I do think that these have a chance of making it in phase 3. In my opinion, trials of drugs that can impact myeloid-derived suppressor cells are also going to be of big interest. So studies are pursuing, for example, docetaxel combinations, and docetaxel does seem to have the ability to clear at least some of the myeloid cells in these patients. There are other combinations being pursued, for example, Sipuleucel T, radium. I've mentioned Ipilimumab already. There's also Ipilimumab being studied with the Tricom, Vaccinia vaccine. There are other vaccine studies being looked at. But I think overall, really, we need to await these data. There's also PARP inhibitor with docetaxel combo with nivolumab, and obviously there's the ENZA and the ABI combinations being studied. But we really need to wait and see what these trials show. I do think a better understanding of the disease biology is going to be key to success and reversal of T-cell exhaustion. So we've pursued, for example, studies targeting CD38 with the PD-1. That paper is in press now. But while we saw T-cell activation, we didn't see much anti-tumor activity. So we need to figure out ways to reverse the immune cell exhaustion, the cold tumors that these prostate cancers have, unless they are mismatch repair defective or maybe have biallelic CDK12 alterations. But at present, I think there's still a lot more to do to make an impact on prostate cancer outcomes with immunotherapy. Thank you for your attention.